Well, hello everyone. I'm Marc Melser. I'm from Punta Gorda, Florida, and this is an opportunity for me to thank everyone who helped train me during my time here, Ray and Steve. I'm going to be talking about something a little bit more common than caval thrombi. And so I'm going to talk about the second prostate biopsy, indications, techniques, and rationale. And you're looking at the Peace River in Punta Gorda, and if you got on 75 out here, you'll be in that spot in about 24 hours. Okay, so you thought you were going to see Florida. You never thought you'd see Florida again, did you? All right, so where is Punta Gorda? You see where we are on the West Coast. We had to talk about the East Coast. There's Miami down there. There's Orlando, Tampa, and down in Naples. Okay. Oh, thanks. And let's take a little close-up look at Southwest Florida. There's Tampa, and there's Venice, and our program is represented in Venice. There's Dr. Carl Klutke. He left Washington University, is now in Venice, Florida. And I'm in Punta Gorda. And down here's Naples. And who do we have in Naples? There he is, Dr. Jonathan J. He's in Naples. And what does Punta Gorda mean in Spanish? It means the fat point. And we have our own craft brewery, and it's very good, and they're called Fat Point. Okay. So indications for a second prostate biopsy. Well, we can use it for a diagnosis. We can use it for a confirmatory biopsy for active surveillance, and we can use it to help map the prostate and plan subsequent therapy. How are we going to do it? Repeat your transrectal biopsy, transperineal biopsy, transurethral or MRI, that's plus or minus ultrasound fusion. And at the start of my residency in July 1986, the following were not in use: PSA, prostate ultrasound, and the spring-loaded gun. Now, for some of you younger urologists, could you imagine urology without those three? Could you absolutely imagine? So, but there was urology before this time. So how in the world did we do prostate biopsies? Well, there she is, the true cut needle, and that's going into the prostate, and Dr. Farah taught us how to do that, and it was a pretty rough procedure. But Ray, remember the days? Steve, remember? Okay, that's how we did it. So, how did we treat prostate cancer in the late 1980s? Well, Dr. Walsh's work of open radical prostatectomy came out in around 82, somewhere around there, and we were taught how to do that. External beam, using dosages lower than what we now have, and we placed I-125 seeds in an open fashion. Can you Jim, could you hear Dr. Bay? 2.5, 1.5, could 0.2. 0.2, okay, so we did that. All right. So along comes the 1990s, I'm out in practice, and we hear what you see is PSA testing and screening. Biopsies were now done under ultrasound. Our biopsy techniques advanced from the sextant to the 12 core, and we were doing stage, and we saw a stage migration, and we all know about this, the earlier and earlier stages of prostate cancer. And how did we treat prostate cancer in the 1990s? Well, we're still doing open radical prostatectomy. External beam got advanced with higher dosages, and then 3D conformal, and the big wave, of course, everybody was getting seed implants, now using the brachytherapy with the template. But with all the biopsies that we did in that era, we created a dilemma patient. We created that patient with a rising PSA, and we didn't find cancer on 2 or more transrectal biopsies. And these were men who had gland sizes that were fairly normal or nearly so. We all had an index of suspicion that you, sir, have prostate cancer. We're just not getting a positive result. So what did we do? Well, we started doing saturation biopsies. We called it saturation, using 20 or more cores with the transrectal technique, just taking more biopsies the way we did. There's your positive yields. And then the paper by Keach, there's a declining rates of prostate cancer going down from 19 to 8 to 7% on 2, 3, 4 respective biopsies. So there was still a yield, but it was declining. And then this was not terribly used a lot, and it wasn't very attractive. A diagnostic TURP, you know, you ream them out really good, but if you were thinking about a radical prostatectomy, it might have made the operation more difficult, or you risk getting a stricture, and of course, you eliminated that man from getting brachytherapy. So we had to come up with something that was a little bit more satisfying. And now I'm going to show you the paper that sort of revolutionized this. It certainly revolutionized what I did. This paper came out in an article from Mayo Clinic in Jacksonville, Florida, and systematic transperineal ultrasound-guided template biopsies of the prostate in patients at high risk. And again, May 2001 in JU. And I'm going to point you to this name here, Dr. Stephen Petro. We have been friendly since the first day of college. And there we are at this year's Southeast section. That's Steve Petro. So anyway, all right, so what did they find? 88 high-risk men, PSA of 18, velocity, and many had high-grade PIN or ASAP. 43% were diagnosed with cancer, 76 had anterior transition zone cancer, and 40% had cancer anteriorly only. The only significant independent variable predictive of the positive biopsy was the volume. The positive group, their volume was about 48 cc's, the negative group 73. So again, smaller prostates, higher risk. And as I reread the article, this is verbatim. Currently, the number of cores that should be obtained is unclear. So that question is answered a little bit later. So I told you I started doing it back in 2001. Here's what it looks like. You got your ultrasound probe on a stepper unit, and there's your brachytherapy grid. And that's what it looks like. There's your spring-loaded gun. So, all right. So, in the Journal of Urology, August of 2013, University of Washington, West Virginia, retrospective analysis of 485 men with prior negative transrectal biopsies. The transperineal biopsies with a median of 59 cores, that's a lot of cores, 47 were diagnosed with cancer, 87% were upgraded to significancy. We heard about upgrading earlier. And most common site of cancer was the anterior apex. Now here's another study. No disrespect to the Donald. Okay, so, and this is a study from the UK. 122 men, 2 prior negative transrectal biopsies, PSA of 18, 58% ruled in for cancer, and half of them were positive cores in the anterior section. And guys, you'll never get that spot transrectal. So, confirmatory biopsy for active surveillance. This is our second indication. I think everybody's gotten biopsy results like this. Yeah? Or like this. I mean, I don't think you'd feel good about offering those men, you know, aggressive therapy. So, what are the goals of confirmatory biopsy? 1/3 of the patients are upgraded on radical prostate Hull mounts. Now, we heard about that earlier. We must detect men with previously unrecognized high-grade disease, and really, we want to improve the selection of men for active surveillance. So let's talk about a man from Sarasota, Dr. Winston Barzell, who did a fellowship at Memorial Sloan Kettering way back in the day. I think Willett Whitmore was one of his mentors, and Jim, he was there long before Ed, long before Bob, but he published data. I mean, he still has that strive to publish, and I know right now he's about 75 and still going strong. Thought to be good candidates for active surveillance. They, in the same sitting, he had transrectal and transperineal biopsies, and there were a lot of men were upgraded, but you see the transperineal did more so than the transrectal. Repeat transrectal failed to detect 80% of the important cancers. Transperineal mapping identified higher risk cancers in 52%. More in his data. In the end, only 30 to 43% were deemed unsuitable for active surveillance. And of those men who had radical prostatectomies, 12 out of 13 had anterior tumors that I tell you would be missed transrectally. Study done right here at University of Michigan, West Virginia, and no, that's Virginia Mason. Transperineal, and this is in Journal of Urology just last month. How many cores is enough? Well, they did a nice job of separating men. 46 had just 24 cores, 12 anterior and 12 posterior, separating at the urethral level, and then most of the men had volume-based cores, like 1 core per cc, and you see that's a lot of cores. I know Dr. Barzell would take 60, 70 cores. After about 30 to 35 cores, I said, this has got to be enough. That's when I've done it. It's just got to be enough. So anyway, what did we find? There's no difference in upgrading to Gleason 7. So 35% in the 24 group and 29 in the volume group. Anterior disease, 65% in the 24 group, 56 in the volume group. Upgrading occurred more often in those with anterior disease, and there was no difference in the complications. So our conclusions of transperineal biopsies, significant prevalence of high-grade disease in those men initially deemed suitable for active surveillance, and a transrectal derived status of favorable risk is not a secure one. So this technique will sample the anterior prostate and find higher grade cancers. It does so by sampling zones, and it takes many needle passes to get there. So how can we do this in a targeted manner with fewer cores and without general anesthesia? Well, here we go. There's your MRI. I'm very fortunate to have a terrific MRI unit in my community. Really a terrific spot. So Journal of Urology in October 2011, this is the work from the NIH, and they did all of the early studies on MRI-guided biopsies of the patients with low, moderate, and high probability MRI scores. Now, I'm not going to get into how they calculate that. I'm sure many of you are familiar with the PI-RAD score. The detection rate was 28, 67, and 90% respectively. MRI fusion biopsies detected more cancer per core at all levels of suspicion. MRI suspicion and PSA density are the only predictors of prostate cancer. More evidence that smaller prostates are more likely to have cancer. Study out of UCLA, a group compared the results of those lesions that were targeted to those that were obtained from just systematic biopsies. The targeted lesion was 3 times more likely to identify cancer. The MRI suspicion score correlated with the overall diagnosis of cancer, and especially tumors over 5 millimeters and those with Gleason 7. And another study from the NIH in November 2013, Dr. Pinto concluded the stronger the MRI suspicion, the increased chance of not only cancer, but higher grade. So its role in active surveillance. Dr. Borowski compared patients who previously were on active surveillance with those who had pre-op MRI and then radical prostatectomy. So a non-suspicious MRI, there was only an 8% chance of adverse pathology. On the other hand, a suspicious MRI, 48% chance of adverse path. In those men with a normal MRI, they can continue active surveillance and some think without biopsy. So again, you're seeing the strategy that you get your biopsy of someone that you think is favorable, like I showed you that path. Maybe all you have to do is an MRI. So our next indication, its influence on therapy, MRI can detect a lesion of about 0.5 centimeter. And this is the proverbial index lesion. It's that lesion which drives the biology of the cancer. Now, of course, we all know that prostate cancer is usually multifocal, but the smaller lesions are less clinically relevant. If the index lesion is treated, the tumor burden is greatly reduced and the propensity to spread is also diminished. So we can use the subsequent biopsy for prostate mapping and its influence on therapy. In 2001, I got involved with cryosurgery of the prostate. I went to training up in New York with Aaron Katz, and I started doing cryosurgery. And there's my technician, and there's our unit, and here's a man who's getting whole gland cryo. And one of the people who taught me cryo was Dr. Gary Onek. There's Dr. Onek, that was the AUA last year. And he's a real innovator. He's the man who's credited with this concept, focal therapy. And he wrote this book. This is 2004. Of course, he's updated his data and his thoughts. With thorough mapping, with transperineal and MRI biopsies, now we can treat maybe just a portion of the prostate gland, something completely different from what we were all thought about. So we saw a slide about the future. So what's the future? I told you. I didn't have PSA at the start of my residency. Will we be using PSA 25 years from now? Will there be other biomarkers? Will we be doing the 12-core biopsy 25 years from now? Will more glands receive focal therapy? And will we do away with the second biopsy altogether, yielding to the Oncotype GPS, a gene study? You've seen that. And with that, I want to say thank you. And that's the sun setting over the Peace River in Punta Gorda. So thank you very much.